Thank you for coming to our August 2025 Virtual Gastroparesis Awareness Month program series. This being what a way to close our whole month of expert speaking, and we end it with Dr. Hiroshi Mashimo. It couldn't be better to have him close it, as I've known him for years, and he always just covers every single detail. He's a very good speaker, so I'm sure you're going to get a lot out of this program. My name is Mary Angela De Grazia De Tucci. I'm a longtime patient, gastroparesis, as well as other motility disorders. I also serve as a volunteer for the Association of Intestinal Motility Disorders, or AGMD. AGMD was incorporated in 1991. We're an international nonprofit organization, and we serve as an information or educational resource for digestive motility disorders, an information clearinghouse for those in the medical, scientific, and nutritional communities, and a forum of education and support for patients and their family. This program is made possible by a grant from Entera Medical and also the sponsorship from Evoke Pharma. Dr. Mashimo, thank you so much again for being here. It's always such an honor to have you. Can you just tell our audience a little bit more about your background?
Sure. I'm a gastroenterologist at the Harvard Medical System at Boston VA as well as Brigham and Women's. I am basically a basic scientist initially, a stem cell biologist and molecular biologist with a background in immunology. That's where my PhD is in. And ever since I got into GI, I've been largely focused on gastrointestinal motility. I'll have one slide to explain why. And that's about when I ran into Mary Angela when I was doing really hardcore science. I continued to do so, but run a lot of clinical studies as well as translational work with my team at Harvard Medical School and MIT. So on my flag, I have no conflicts to declare.
Excellent. We also have with us Melissa Adams Van Houten. She will be assisting us with the Q&A. Melissa, can you introduce yourself?
Yes, my name is Melissa Adams Van Houten. I was diagnosed with idiopathic gastroparesis a little more than 11 years ago in February of 2014. I currently serve as the AGMD's Public Policy and Outreach Director, and I manage several online gastroparesis patient support and advocacy groups.
Thank you, Melissa. So, Dr. Mashimo, tell us about these medications that cause dysmotility. And boy, oh boy, you have a lot of information to share.
Thanks, Mary Angela, and thanks for all the group does, including, I'm sure, in the audience, the supporters for AGMD. So it's a great honor to be here and during Gastroparesis Awareness Month. And what I thought I'd do, because of the explosion of the use of GLP-1, such as semaglutides, for both diabetes control, which obviously complicates gastroparesis or either way. It's both the horse and the cart, as well as its use in obesity. I thought I'd bring that a little bit more to forefront, but because I'm kind of wrapping up, I thought I'd make it relevant both to care providers as well as the many patients that suffer to think about some of the overlap with gastroparesis and show that it's not just the stomach that's affected, but through multiple mechanisms, we hope to, have a more multi-pronged approach in the future. So today I'm trying to talk about the complexity of gastric emptying with key points that solids obviously empty slower than liquids, as many of you already know. But part of that feedback in the stomach emptying is that different nutrients slow the gastric emptying differently. So clearly, you're probably told, or patients are told, hey, decrease fats or oils, which slow far more than proteins or carbohydrates. But the mechanism behind this is really what's getting to the forefront of the future in treatments. Also appreciate that common medications, not just GLP-1, of course, which is blown out of proportion, but these are also implicated in altered gut motility, not just the stomach, but reflux and constipation, diarrhea. And these, of course, exacerbate the nausea and bloating and all these overlap symptoms that there are with gastroparesis. Opiates is always a dinger. It has multiple sites of dysmotility in the gut. And I want to bring forward to all of you, both patients as well as care providers, a special concern for the narcotic bowel syndrome. And clearly, this is not just constipation. So I'll explain that in terms of why early diagnosis is important. And of course, the GLP-1s that I'll highlight. So I got in this field surreptitiously when I was a GI fellow at Mass General Hospital. We were using animal models by specifically knocking genes out to find what their function is. And I was only GI fellow there. All were cardiologists and developmental biologists. And lo and behold, when we knocked out a very, very important neurotransmitter in the gut, called nitric oxide. It's actually a gas. And when we knocked out the gene for it, what you see on the left is actually the knockout gene of nitric oxide synthase. And you can see that the stomach is huge here on an X-ray. This is a mouse, not a human. And it's the normal mouse is relatively small in terms of food and so this became historically the very first animal model for gastroparesis. It had many other manifestations, but that kind of got us thinking, wow, here's a gas as a neurotransmitter. Who would have thunk it? And this really got me into the motility field. So what is gastroparesis then? Well, like the name says, gastro meaning stomach, paresis meaning kind of paralyzed. But there's two components to that diagnosis. One is you have to have the delayed gastric emptying. And often clinically, we do this with either scintigraphy, where you take scrambled egg and a toast and you lie on this table for 1 to 4 hours. Now there's other emptying studies, a breath test, for example called spirulina, breath test, and there are capsules. Some are now coming back on the market that will tell you not only the transit time for stomach emptying, but also the intestine and colon. But the second part of the definition has to do with absence of a fixed mechanical obstruction distally, meaning pylorus, the sphincter that is between the stomach and the intestine, and anywhere in the large or small intestines. So that generally, at least for the close part, meaning the stomach and the early intestine, is done either by an upper GI small bowel follow-through, excuse the initials, or in the upper endoscopy itself. So there's two components to fulfill this. But you have to know that while we use the word gastroparesis, I like to think of it as gastropathy, meaning some dysregulation, because in the end, overt gastroparesis is only on the one end of the spectrum where it's paralyzed. And even if you were to do a scintigraphy, as many of the patients know, sometimes it looks normal, and the next day it'll look very abnormal. So even our tests are faulted because we're only taking one-time snapshots of how our stomach is emptying. But in the beginning, we just simply say dyspepsia or some kind of indigestion, fullness or early satiety, particularly after meals. So that's on the other. And as we look at the mechanisms, we realize just like with the heart, which you have dysrhythmia or bad rhythm, there's also what we call antral hypomotility, where the lower part of the stomach isn't moving well, or that's really baggy and starting to dilate. Or, as I'll explain from a review of the gastric stomach and its different compartments, that the fundic or proximal upper part of the stomach it doesn't accommodate food, so it doesn't relax to meals. And that might explain part of the issues with both early satiety, meaning getting full easily, versus even having very rapid stomach liquid emptying. So these are some of the components that go. And of course, this is not purely a stomach issue because there's often a small overlap. There's often a large overlap with small bowel dysmotility. So, what are some of the key concepts in this gastropathy? And it's really important for future rational therapy. Oh, I'm sorry. Are you able to hear me okay? Hello?
Yes, we
Uh,
can hear
I'm
you.
not sure if I'm coming through or not.
I can
Yes.
hear
Let's
you.
check.
Yes,
I
you're
can hear
Oh,
fine.
you.
okay, sorry.
You're fine.
I just, for some reason, got this note saying, "Hey, turn on your microphone." I was panicking. All right. Part of the key concepts is that the stomach is not a simple bag. There's different areas. So it's not one bag, but different functional areas. And more importantly, the solids are emptied differently from liquids. And then there's a relation between the muscles and nerves that allowing coordinated emptying, and that there's a feedback of nutrients. This would be very important for GLP-1 or understanding them to delay gastric emptying. And that feedback comes largely from the intestine when the nutrients hit the small intestine. And of course, you hear this word over and over again that there's a brain-gut axis, a communication between the brain and the gut that not only goes in one direction from brain to gut, but the gut feeding back to the brain, not just for satiety or feeling full easily, but also driving that appetite control or even becoming anorexic. So this goes in both directions. It's easy for us to say, oh gosh, stress causes ulcers. But you also have to remember that inflammation in the gut, like ulcers, can also affect the brain, not only in terms of how we perceive pain, but we also know that it can change our sleeping habits or mood, like depression and anxiety. So it's a two-way street. And of course, when we talk about gastroparesis, you need to appreciate that there's a big interplay between each of these components. We talked about gut dysmotility or poor movement, but with it comes, and I don't know again if it's the horse or the cart, but I tell people they both move together. And that's inflammation in the gut, causing this catchy phrase that's being used a lot in the press called leaky gut. And of course, microbiome, the bacteria and various organisms that live happily or should be living happily in the gut that become dysbiosis or irregular or bad kind of bacteria start growing, much like weeds grow in a garden. And these can lead to increased fermentation, for example, with more gases, bloating, belching, more farts, and etc. So this is actually the complexity that we can't just think it's a stomach problem. And part of this functional part of the esophagus has to do with breaking it down simplistically into a proximal stomach that accommodates the food so that you can eat more than a fistful size of a meal and not throw up or not have a lot of belly pain. That proximal stomach is regulated by that very same nitric oxide that got me into this field. It's a reservoir. Whereas the lower part of the stomach has this outlet resistance through the sphincter called the pylorus. And the pylorus allows it to sieve the big a way to hold back the big particles and allow little particles to go through this channel. And when we do this, then much of this food that you're eating has to be made into those small particles through peristaltic activity. And that means that it's got to churn away and mix it with acid and make it into small little, what we call chyme, that allows us to pass through that 2 millimeter or so really small pylorus into the intestine. And driving this is also as a pacemaker, much like the heart, but not like a node in the heart, which is somewhere in the mid stomach and these waves march down at 3 cycles per minute. So when there's a dysfunction in the stomach, there's many components that are hit. One you might think for decreased sphincter tone would make your reflux more, for example. So there's an overlap between reflux symptoms. This is that early satiety, feeling full because you can't relax in to accommodate the more volume of food, and even nausea and vomiting. Dysrhythmia is one where the 3 cycle per minutes don't come any more, so you can't really churn the food as it should. And sometimes this whole lower part can be quite dilated, not have these waves that would triturate the food, meaning make it into small particles, and notoriously, we know that we can form bezoars or big collections of uh, indigestible vegetables, for example, in the stomach that can obstruct. And of course, this area here, the sphincter, can be either high tone or low tone, meaning you can go into spasm, not allowing food to come out, or it can be wide open together with the antrum not working, in which case it's quite baggy. One concept to remember is that then the liquids empty very differently from solids. In fact, liquids start emptying very quickly, but it's driven by whether there's a high pressure zone here versus a low pressure zone. So not to sound like a weatherman, but food is going from high pressure to low pressure. And as you can imagine, if this high pressure is lost because we don't have proper regulation of this accommodation, it can stagnate in here. On the other hand, often in early diabetes, for example, this accommodation is not there. It's actually high pressure, and the liquids will empty faster than normal patients. On the other hand, we talked about solids, and solids really depends on how much trituration or grinding down there is. And excuse the Chinese characters here, we don't get my Eastern side of me, but this kind of retropulsion is what is allowing the foods that don't go down this sphincter or through the sphincter to be kicked back so that another wave of contraction can come down to the stomach and crush the food at this area called the terminal antrum. So that's how we get this chyme. And you could just imagine if there's poor rhythm to coordinate that contraction, or if you just have plain, really poorly digestible, let's say broccoli or something, then it'll stay here, it'll stay here. And what you really need at the very end of all this coming out and spurting these little foods is at the very end, there's what we call a giant migrating motor complex with the main sweeping motion that at the end will go boom and dump out even the broccoli that couldn't have been fully digested. Now, it doesn't mean that those indigestible foods are bad for you, as some people like to think. It depends on the condition that you have, because many of the foods that we tell patients, hey, don't eat this, don't eat that, I'm against doing that mainly because I tell patients, see what you tolerate. Can you think about it? If you think about if you had to take out all these good foods like broccoli and cabbage and things like that that have other good effects, then we're basically making people food cripples. And so I tell people, even if you can't take a broccoli, change its consistency. I tell people with severe gastroparesis or gastropathy, blender's your good friend. You can still get all the nutrients without making it into a juice where you sieve away the fiber. And now we realize things such as plant-forward diet is helpful in the long term because those fibers are exactly what good bacteria in the gut need to make the good products that we call postbiotics. So remember, the bacteria are the things that we see in probiotic, and the prebiotic are the foods that help the bacteria grow, the good bacteria, hopefully. And the postbiotics are these short chain fatty acids and various nutrients that keep the gut happy. So The other component that's relevant to understanding GLP-1s then is that there are receptors in the first part of that small intestine and downwards that are, you might say, chemical receptors that distinguish between fats, proteins, and carbohydrates, for example. And almost all of these will feed back and tell the stomach to delay gastric emptying or slow it down. And this actually is why GLP-1 agonists are being used to actually slow down the stomach so you feel full easier and is used for obesity treatments. It is also going to have many other uses, but there aren't many hormones from here other than motilin and ghrelin, which will help actually hasten the emptying. So most of these, what we call vaguely mediated uh, uh, agents that are coming as from the chemoreceptors and being stimulated, feed back to the stomach and delay it. This is a busy slide, but one that we had shown to show that this brain component has both uh, excitatory and inhibitory components, which then feed back into the stomach. So that's really the brain-gut axis that we speak about. But what's going on here, feedback. So these kind of feedback mechanisms will also increase, for example, perception of pain in conditions where there's a lot of inflammation here. It's not that the pain itself is just from inflammation, but the threshold to have pain, bloating, feeling is feeding back to the gut in this direction. So some of the most common medications causing gastroparesis, high up on the list, of course, are the opioids, the morphine-like compounds. But you have to remember that anticholinergic medications are in many, many common drugs, including things such as allergy medications or antidepressants have anticholinergic effects. So these are all overlapping. Calcium channel blockers that you may be using for high blood pressure, or SSRIs, what we call it, or SNRI, which are non-specific ones, also used for anxiety, PTSD, etc., are also feeding back and telling the stomach not to empty as fast. Antipsychotics, even some anti-seizure medications that I didn't say, proton pump inhibitors. And now we realize, of course, with the rash of GLP-1 medicines like semaglutide, exenatide, etc., that these really slow down the stomach. Now, why am I talking about diarrhea? You would think that if it's gastroparesis, nothing moves, and you should have constipation. And diarrhea or liquid stools, people mean different things about diarrhea as one would with constipation, because constipation could be just straining, even if you're going every day. But it's incorrect to think that constipation and diarrhea are opposite sides of this motility. In fact, they go together often. So what I hear from my patients often is, I'm not going every three, I'm not going other than maybe 3, 4 days. And when I get this hard plug, I just soil myself and can't get to the bathroom in time. It's all liquid. Well, they go together often. And some of the common medications, you'd have to look at the list and say, are there antibiotics that cause dysbiosis? Metformin for our diabetics is another common cause for diarrhea. Laxatives, promotolides, obviously, chemotherapy, drugs, antacids, especially those that contain magnesium compared to, say, calcium, can be quite inducing of diarrhea. Proton pump inhibitors, now that a lot of people are on omeprazoles and pantoprazoles, etc., are also can cause diarrhea. And the new acid blockers on the market now called PCABs, or potassium competitive acid blockers, which I'm sure many of you are hearing about or starting to prescribe, are certainly along the lines that cause diarrhea, both directly as well as indirectly through, again, gut dysbiosis that you would expect from blocking acids so strongly, and we get different kind of bacteria downstream. Non-steroidal anti-inflammatory drugs like ibuprofen, colchicine, the SSRIs I spoke of for depression and anxiety, for example, and statins used like water now or given out like water is certainly another one to think about. But I also want to highlight that if you're having these kind of extremes of diarrhea and constipation or even diarrhea alone, certainly diet plays a major role in this. And the most common, at least here in the United States, is milk products that have lactose or cow milk products. So you can change the plant-based milks, but cow milk and etc. have lactose. And me being Asian, of course, I have lactose intolerance as an adult. It's kind of in the genes of, lacking this quickly. But almost anyone, if you suddenly drank, let's say, a gallon of milk, and even if you were Swedish, meaning less likely to have lactose intolerance, you can bet it's going to start bloating you. The other common ones are artificial sweeteners that have crept into our diet, particularly because our diabetologists say, okay, don't take sugar into your drinks, which is true, but these artificial sweeteners, almost by definition, are not absorbed well, so that causes diarrhea. Caffeine is a very common one. If you're in the New England area, we have a lot of Irish folks or Western Europeans, and we clearly need to rule out celiac or celiac sprue, which is a genetic issue. But there's also what we call celiac, or I'm sorry, gluten sensitivity, not necessarily with the gene defect, but sensitive to gluten, which means wheat products like your usual pancakes and breads. So you can test for these. Crept in there are the fructans, the major kind of carbohydrate that's found in that FODMAP diet. And we call this also part of the gluten sensitivity. And so fructans can also be tested by a breath test. And we often do this to talk about that gluten sensitivity, even if you don't have a blood test or intestinal biopsy showing that you have celiac sprue. What's crept in our diet so badly, of course, is corn syrup, or high fructose is the kind of other name for it without saying corn syrup. It's crept up as the cheap alternative to sucrose, and so it's highly in drinks today. So if someone tells you, for example, that fruit juices are good for you, not for a diabetic, and certainly not for a gastroparetic, because these sugars are like gunpowder because the liquids are emptying fast. And it is not good because fructose does not have your usual insulin response as you would expect from sucrose itself. So I would be against high fructose drinks or sugary drinks of any kind, and worse yet, of course, sweet drinks that are laden with artificial sweeteners or corn syrup. Now, what I have to say is that fast diarrhea doesn't mean fast transit. And the reason why we get this diarrhea often in slow transit is that just like a stream, when it's running well, the water is fresh. But if you block that stream and have a stagnant pool of water, you often know in a puddle it starts smelling like methane, starts smelling like rotten eggs, and that's often what can happen in the gut. When there's no good stream, the bacteria changes. You get dysbiosis. So again, don't know what the cart or horse is, but they both move together in the sense that a stagnant pond starts getting different bacteria. And that can be what happens in the gut as well. So, as I said, we can have both constipation and diarrhea going together of many causes, including the fact that the bacteria has changed. And when there's bacterial overgrowth, not just bad bacteria, then any of those sugars that I mentioned will make a heyday for the bad bacteria and create more methane, which makes the farts light or ignite, and hydrogen sulfide, which gives it that rotten egg smell. So clearly, it's a complex interplay between the gut, the diet, inflammation, the bacteria, etc. So one thing I'm going to alert, because I'm not going to make a total, discussion about gallbladder disease, but many of you may have lost tremendous weight during the process where you have gastroparesis, and that puts you more prone to increased cholesterol synthesis, and the fasting or lack of food stimuli to the gallbladder causes hypomotility. So in the setting of rapid weight loss, and sometimes it's intentional, right? For our bariatric patients that we're trying to make them lose weight, then they're at high chance of getting gallstones. And of course, those symptoms, particularly a right upper quadrant pain, sometimes radiating to the back, should alert you to make sure that you don't have gallstones, particularly when it's meal related, and would might be a call out to have an ultrasound or some imaging study done. Opioids, I mentioned, is the big dinger. And not only does it cause constipation, but it's really a hypomotility or low motility throughout the gut. And it can even exacerbate nausea and vomiting, not just through delayed gastric emptying, but also in the brain. And we're going to talk a little bit about this big alert. But it also has effects in terms of causing spasm at the sphincter of Oddi, which is at the pancreas end of the pancreas, called SOD dysfunction. Reflux, gastroesophageal reflux disease, also can be worsened by opioids, and we can even get a condition where the small bowel doesn't move, called ileus, and worsen dyspepsia. So opioids have all these ranges of function, all leading to slower output, and this is exactly why we have to try to replace these with better medications. Now, the big alert here is for narcotic bowel. And I'm not sure if this is getting blocked. My screen seems to uh, have all sorts of things on the screen. But so narcotic bowel is not opioid-induced constipation. In fact, what happens in narcotic bowel, and very much underappreciated, is that actually the pain gets worse or doesn't really resolve even when you start increasing narcotics because you have pain. In fact, what happens is that this is quite common. It's even 5% of chronic opioid users. And the common setting, at least referral to us, is because narcotics aren't helping. They say, hey, what else can we try? Well, it turns out that the pain itself is paradoxical, and increasing more opioids actually worsens the belly pain often, and reducing it then makes it better. The reason why it's behaving this way is that now we know that with chronic and large uses of narcotics, eventually there's inflammation centrally, meaning in the brain. And there's a glial activation which is driven by an inflammation, which makes you far more likely to have hyperalgesia, meaning more likely to feel pain. So this is a big shout out that this is probably very underdiagnosed in chronic opioid users. And really, early recognition is key. Hopefully, you'll have the slides that I'll give as a handout, so I won't go to the details. But the important thing is it's sometimes very difficult to wean patients off, particularly when they've been on chronic opioid use. And so close monitoring, and sometimes, and often I should say, in the inpatient setting, is required. And to replace them judiciously with other medications such as anxiolytics, antispasmodics, and also making sure that they're going to go, but with laxatives and even some peripheral opioid antagonists, meaning reversing some of that. Very difficult. Now, for the care providers and motility people, I do want to make a shout out because many of these classes of drugs are used. And I put in red, I mean, they're used also for belly pain, not just depression and anxiety, which is on the first column, but a shout out in terms of what it's doing to GI transit itself. And the second column really says what slows it down. There are ways to avoid it. For example, if you're on tricyclics, antidepressants and things for either pain, depression, anxiety, etc., then if you're already having slow stomach emptying, you might, for example, shift to dizipramine or nortriptyline rather than, say, higher doses of amitriptyline. Similarly, if you're looking at trying to increase transit rate while using these, then one of the possibilities would be to use SSRIs, both for decreasing symptoms as well as possible uh, treatment of the pain component. But uh, paroxetine doesn't seem to do that, so that's an exception. Now, the third star that I have is for nausea, and we can use many of these for nausea. And what we can say is that particularly mirtazapine and those that use a lot of neuromodulators for treating functional illnesses or even gastroparesis, mirtazapine has come up to a more used drug because of its decrease in nausea. And so these are just a little shout out onto some of the drugs that some of the motility folks are using, and hopefully this, which is put together by Doug Grossman, is maybe helpful for our providers, and again, will be in the handout. Now, I'm not going to go through all the GLP-1 receptors, but this is only the tip of the iceberg when it comes to all these things that have hit the market. And all in all, I can say that GLP-1 drugs typically used for weight loss are at higher doses than those for diabetes. The root, most of these are injection, other than Rybelsus, which is an oral form. And these are all approved for adults, but very few are approved for children. Now, important thing is that if you don't tolerate one, you can still switch, and it could be effective still both for diabetes control as well as obesity control. The problem with the latter, of course, is that you might say the readout in terms of how much weight you're losing is on the order of 3 months, 6 months, or even longer. So that kind of trial period is much longer than, say, quick, response to GLP-1s to glucose control or hemoglobin A1C or whatever endpoint that your physician may be trying to monitor. Now, as far as potential benefit, this is where it gets exciting because we now realize that GLP-1 has multiple effects. If you were diagnosed, for example, at one point with fatty liver, for example, we know that it starts reducing the metabolic syndrome, which includes reducing the cardiovascular risk and the kidney problems, as well as the liver problems. I realize this is a busy slide, but it also has been shown to enhance that pancreas response. And to the brain, interestingly, not only is it affecting the nerve protection, which is really new, which is why they're thinking about the neuroprotective effects of GLP-1 for things like Alzheimer's and Parkinson's. There are studies actively looking at these for those with really long-term diabetes, for example. It's also being looked at because the peripheral, meaning numbness that you have in your fingers and feet, may also be somewhat protective or even neuroregenerative with GLP-1s. So these are areas of quite great excitement in addition to reducing cardiac risk factors. So really is it having these central effects, which it looks like it is. Um, the central effects also I should mention is many people that I have patients on GLP-1s, they say, you know what, when I walk by a McDonald's, or maybe I shouldn't say McDonald's, but some fast food place, I don't feel hungry anymore. I don't feel like this food craving from the smell. And certainly enough, the kind of reward and you might even say addiction to certain sensory inputs are changed. So, so much so that it's being considered for example, eating disorders. And it's also being used, for example, for addictions, like for alcohol and other drugs. So again, a very multi-pronged, effect of GLP-1s. And who would have thunk it when it was just coming out of the intestine and we thought, hey, this is something mainly just to affect the stomach emptying and satiety. No, it goes well beyond it through these multiple prongs of effects. Now, there are some things to look for, and again, a busy slide, but we do know that nausea and vomiting are high up there in terms of some of the side effects. And again, busy slide, but for the care providers, I would say that in the handout, you might consider then symptom-based initial management of these side effects and let the patient know that this isn't really an adverse event in any way. It's a known effect, including constipation and diarrhea. And these are the odds ratio that's increased with this, so huge odds ratios. And so, for example, if they have nausea, you should avoid strong smells and eat kind of blander foods like crackers. You might quell some of that nausea with kind of, not to sound like Chinese medicine, but often use the gingers and the mints, for example. And vomiting, stay well hydrated. Diarrhea, obviously drink plenty of fluids, but most importantly, stay away from animal milk products. And for constipation, while people may say, hey, it's not enough just to take fiber, but nevertheless, I advocate these kind of fiber foods, not because it's necessarily the fiber changes the consistency of the stool simplistically, but we now know, for example, that the non-soluble fiber that's hitting the gut keeps the good bacteria happy in your gut. So it's a multiple effect that fiber or plant forward diet, which I highly advocate, is doing to your gut to keep the microbiome happy. So less common side effects, we did mention gastroparesis. It also has effects on gallbladder and pancreas and bowel obstruction. But do remember, if you're a patient and get these off of GLP-1s, do seek urgent care or your doctor, particularly when you have severe vomiting, diarrhea, severe belly pain, inability to pass gas or move your bowels, and jaundice. Now, this is only the tip of the iceberg. So to bring things to a close, that we have time for questions. This busy thing here is, I don't know if you can see it here, is really showing that all these hormones feeding back from the intestine are largely inhibitory and makes you actually not empty the stomach as well. And now we're going to use other hormones created by all these other cells down the intestine, of which these are some of them here, in the future drugs for not only obesity, but for diabetes control. And this is a slew of dozens of medications that are probably going to come up in the next few years. So it's a big pipeline of drugs, and you're welcome to see some of my review articles that go with this. The GLP-1 paper just got published last month. So again, if you look up Mashimo together GLP-1s, there is a synopsis of this. So really, upcoming non-GLP-1s include, for example, one called ARD-101. It's initially being used for Prader-Willi in terms of hyperalgesia, hyperphagia, meaning that it's a behavioral modification maybe because this one tastes like it activates a bitter taste receptor. So that's not GLP-1, but the other ones like amylin and GLP-1 co-agonists, meaning kind of mixed agonists, are coming up. CB1 is yet another one, and kind of broad spectrum of enteric hormones called APH012. So they don't have names yet attached, but these are probably more ripe in terms of coming to the market soon. So to wrap up, there are many common medications that cause altered gut motility, including those such as I mentioned, allergy medications and other over-the-counter medications. Uh, and then there's a lot of overlap of symptoms, or these other entities can coexist, such as reflux, the gastroparesis, constipation. I did make a shout out for gallbladder disease, for example, gallstones, but diarrhea, nausea, bloating. Um, and that gastropathy, if that's what we call it, is a complex interplay of the muscles, nerves, the brain's going both in upward direction and downward direction in both motility as well as in the perception of discomfort. Various medications can cause this. Diet. I made a shout out for keeping the healthy microbiome. More importantly, the diversity of microbiomes. So small amounts of different foods are very important rather than being told, don't eat this, don't eat that, and becoming very much a kind of food phobia uh, where uh, your diet ends up very, very restricted. I hear this so many times over. And in fact, on a London Times article that I was quoted in, I said, poison is a matter of dose. So if you're saying, I can't eat a bowl of beans, just have a very small amount, chew it, but keep your healthy bacteria with diversity of the bacteria there. You're going in the wrong direction if you start restricting foods more and more. I mentioned that diarrhea and constipation can be different sides of the same coin, driven by dysmotility and, more importantly, the dysbiosis that comes from the poor gut transit. Opiates, very, very common, but special concern again to the narcotic bile, where increasing opiates make your pain worse. Very hard to manage, I have to say, particularly at a tertiary center. And the GLP-1 agonists is certainly had as an explosion of use, mainly driven by diabetes and obesity, but clearly, hopefully, the guidelines in terms of symptom-based initially modifications would be a way to do this. So I'll close there for questions. This is a question. This is a picture I took at my place to thank some of our team members. This is James Fujimoto, my long-term collaborator, who recently got the Lasker Award, which some of you know is our American equivalent of the Nobel Prize, as well as the Innovation Award from President Biden, and my long-term mentor and friend, Raj Goyal, well known to AGMD, who has retired but remains very active as I visit him for dinners and continue. He continues with many publications. So I'll end here and open up the mic.
Thank you so much. Oh my gosh, so much information to process. I told everybody. I'm going to hand the program over to Melissa, who will take questions. Melissa?
Absolutely. Does anyone in the audience have a question for Dr. Mashimo? You can just use your raise hand function or Miss Allison.
Oh,
Miss Allison,
hi.
do you have a question?
Yes, I
Hi.
do. Sorry about that. Hi, good morning, Dr. Mashimo. Thank you so much for your wonderful presentation. Really appreciated it. I just had a couple questions. The first one was talking about the functional parts of the stomach. Is there a way that we can measure those different functions of the stomach?
Great question, because I wish there were for different parts. And while there is as a research tool, the only one we really have is the crudest, which is the stomach emptying through that scrambled egg toast scintigraphy, which hopefully most people are using that. And we're trying to standardize it through American Motility Society, et cetera. So that becomes the measure, and making sure that we, span it out to 1, 2, and 4 hours if it's abnormal. Other than that, sometimes spirulina is used, but all these are emptying. It's not looking at, hey, how sensitive are you to a stretch, which is the accommodation part. And that is called barostat, but hardly used. We stopped doing it because of how difficult it is to do this. Even my former mentee, Brad Quo, stopped doing that at Mass General, and Walter Chan, also my mentee at Brigham and Women's, who directs the motility there, has not uh, been doing this. So the good measures that you might say, more specific, have really not been available. You might also say, hey, what about pylorospasm? And why don't we look at the sphincter and looking at how tight it is? Again, manometry in the pylorus, meaning pressure transductions in the pylorus, has also fallen out. So sorry about that. So um, so to answer your question, no, we don't have these unless you're in a research situation. I'm so sorry about my Alexa going off. So so that this is one of the issues is that we don't have these specific things, and hopefully we'll have other biomarkers to look at this. Very common in diabetes is also the kind of vagal, you might say, dysautonomia. And that can play out in many ways. Some people with very bad gastroparesis, and there may be some in the audience who start having, for example, autonomic neuropathy, sometimes called small fiber neuropathy, where they get up and they get dizzy easily, and all sorts of issues with the autonomic system. And there are ways to diagnose this, for example. Certainly, Brigham and Women's is a center for doing small fiber neuropathy workup. But at the end, we realize it's very complex. And many of the people previously diagnosed, for example, with idiopathic gastroparesis, may fall in this category of this complex of kind of autonomic dysnomia. And again, very poor ways to test this. There are ways to test it with your Apple Watch, for example, for beat to beat variation changes, where it's dysfunctional because the vagus and autonomic system drives that breathing variation in the heart rate. But I hope that was helpful. Unfortunately, we don't have simple measures to look at each of the components of the stomach emptying.
Thank you. I really appreciate that. My next question was just about hormones. You mentioned hormone role in the stomach. Are we seeing any sort of adverse reactions to hormonal birth control in the stomach?
Yeah, I did do a paper on some of these other agents, such as particularly estrogens and even anti-androgens, et cetera, and very much so. And that interplay is very complex. For example, you might think that, let's say, androgens might indirectly have a better stomach emptying through some of the effects on muscle. Unfortunately, it's not uniform. So many of the hormones, for example, besides the motility effect, which they can have, and most of them are hypomotil, meaning slowing it down, also has effects, of course, on nausea. But a big shout out, particularly on birth control, is that, as you may know, it makes you even more prone, at least to a small population, for clotting behaviors. So you could have, for example, intestinal ischemia, not necessarily emergent, but certainly urgent, and that can mask or overlap with symptoms of nausea, vomiting, abdominal pain. So there's a shout out that you may not have necessarily motility, but the effects, the symptoms that the patient, feels, can mimic it, and so should uh, kind of be an intention to get workup for it.
Thank you so much. Really appreciate it.
I think that Miss Letitia also has a question.
Yes, ma'am. Thank you. Thank you, doctor. That was really amazing information.
Thank
Um, a lot of things I had never heard, and I'm glad to hear you say that at some point we can introduce our stomach back to the healthy vegetables. Because I was able to do that at one time. Like I was diagnosed with severe gastroparesis, and I hear a lot of people talking about the early fullness, but not talking about like at some point in my process, I've had days where it seemed like I couldn't eat enough. And I've talked to other gastroparesis patients that said they have experienced that as well. And then it seemed like you can't cut it off and then you get too full. And then of course you get sick. Have you, ran into that or seen any patients that have those moments where it seemed like they can't eat enough?
Oh, absolutely. And this has to do with somewhat what you're eating and appreciating the nutrient or chemical real effect that it has. So it's not just volume, it has to do with making really kind of uh, it's really individualized choices.
Mm-hmm.
And so when I listen to my patients very carefully and going through the granularity of this causes me discomfort, whereas this just seems to empty much quicker. That's kind of what I incorporate. But in general, if I had to put this, paint with a big brush, I probably say that what you really want to do is first, particularly if you were diagnosed with gastroparesis, is blender's a good friend, meaning that
Yes.
if you're having difficulty with less digestible fiber things, then blenderize it. Because as I mentioned, liquid emptying or slurries empty much faster. But at the same time, the big caveat is don't go for very potently sweet or it's mistaken to say high calorie, but sweet drinks because you can just imagine that if you have lots of sugar coming down into the intestine in the liquid form, there's nothing holding it back. The intestine has a heyday. It totally turns on all those intestine hormones to feed back. And often we have early on in the disease kind of a fast liquid emptying compared to a slow, simultaneously slow solid emptying. And so you have to kind of think yourself and for yourself, make a diary of what you took, what causes symptoms, and try to dissect out, hey, is it these sugary drinks that were giving faintness and nausea, or by giving a slurry of more complex, rich in both carbohydrate and protein, for example, compared to say fats, is that making it better? So hopefully that's helpful. But as I talk about gut inflammation, etc., clearly the buzzwords to consider are anti-inflammatory, an antioxidant diet. And largely this comes from a plant-forward diet.
Thank you. Thank you.
I think we are getting close to being out of time. So I'm going to thank you, Dr. Mashimo, for joining us once again. Very informative, educational talk, and we appreciate you being with us. And I will hand this back over to Ms. Mary Angela.
Thank you, Melissa. One of the things that I love when Dr. Mashimo is talking, and maybe it's that scientific part, but he's always giving the whys. So he just doesn't make a statement, but he fills it in with, this is the reason why, which really makes it so much more understanding, at least for me. And I always learn. I always feel like I went to college with Dr. Mashimo, back to college, and now I'm just absorbed with all of this. And I just can't thank you enough, really.
No,
You
it's a
have
great
been,
pleasure and honor, and I have to thank you for the great work you do, in education and support of patients. And I can't thank you and the AGMD enough. You've certainly been a beacon of hope for and ed source of education to our providers as well as our patients.
you're very kind. You have been just so dedicated to our organization all of these years. I was saying that I've changed how I look, but Dr. Mashimo is still the same. If you look at pictures from our first symposiums to now, it's like he's the same. You can identify him. Thank you really for taking the time today. And you know the score with me. I always end these programs the same way because I only know how to speak one way, and that's right from here. Dr. Mashimo, you are my hero. You've been my hero for many, many years. And all of you patients are my heroes. I call you the quiet heroes because you are suffering every single day, trying to get through all the challenges that come, not only physically, but mentally, and all the peripheral things that go along with you have gastroparesis. If you feel alone, know that you're not. My thoughts are with you every single day. This is my passion. You are my family, my extended family. And my heart remains with you every single day, as do my prayers every night when my head is ready to hit that pillow. I think of all of you and I pray that perhaps in your lives you can have maybe one good moment, and we can expand on that. That would be great. But prayerfully, you can take away a lot of this information that you've learned and incorporate it into your life to give you that hope and make things better for you. God bless you all. Thank you so much again, Dr. Mashimo. Thank you, Melissa. And thank you all. God bless you. Take care. Bye-bye.